Hi there, my highly esteemed and valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building amongst the healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to urge you to sit back and spare me part of your precious time as I share useful tips with you. So question number 1 reads, which of the medications listed below reduces the efficacy of ticagrelor? Is it omeprazole dosed at 20 milligrams orally once a day, or aspirin dosed at 325 milligrams once daily, or is it metoprolol succinate dosed at 50 milligrams once daily, or would it be Fosinopril dosed at 40 milligrams once daily orally? I'll give you 10 seconds to choose the correct answer. So aspirin 325 milligrams orally once a day it is. A Plato trial, PLATO trial, compared clopidogrel with ticagrelor to evaluate a composite endpoint of cardiovascular death, myocardial infarction, or stroke. The study also showed that patients taking ticagrelor in North America had a significant interaction with a p-value of 0.045 between high-dose aspirin with less effect of ticagrelor compared to other regions of the world. The study, which is ticagrelor compared with clopidogrel by geographic region in the platelet inhibition and patient outcomes, abbreviated as PLATO trial, concluded that regional interaction could have been from chance alone. In statistical analysis by 2 independent groups, aspirin maintenance dose was identified as the potential explanation of the regional differences. Low dose maintenance aspirin, which was a dose below 100 milligrams per day with ticagrelor, was associated with better outcomes compared with the clopidogrel when deeper analysis was done. So that explains why alternative B is the best alternative in that question. Let's move to the next slide. Which of the factors listed below is known to decrease the efficacy of thiazide diuretics? Is it a reduction in renal function in which the creatinine clearance becomes less than 40 ml per minute? Is it the use of oral antacids, which are known to reduce the oral bioavailability in the gastrointestinal tract? Or is it inducers of CYP453A4 enzymes, which are known to reduce the serum concentration of thiazide diuretics? Or is it a reduction in liver function as reflected by a 50% reduction in synthetic function? I'll give you 10 seconds to choose the correct answer. In my opinion, the correct answer is a reduction in renal function in which the creatinine clearance becomes less than 40 ml per minute. Remember, thiazide diuretics require adequate renal blood flow and function in order to be secreted into the proximal tubule of the nephron. If thiazide diuretics don't make it into the lumen of the nephron, they won't be able to inhibit the sodium chloride co-transporter in the distal convoluted tubule. And if creatinine clearance or estimated GFR are reduced below 40, the efficacy of thiazide diuretics appears to decline. Depending on the guidelines read, the cutoff for recommendations use can be a creatinine clearance of less than 30 or less than 40. It varies from literature to literature. And I would like to emphasize that thiazide diuretics aren't metabolized by the CYP450 enzyme system at all. They aren't metabolized in the liver, and thus synthetic functions of the liver aren't relevant in the use of thiazide diuretics. And they aren't commonly affected by antacids either, and they are known to increase the concentration of uric acid and serum calcium and glucose levels. So those are just by the way. Let's move to the next slide. This question reads, you are attending a patient with HFrEF, heart failure with reduced ejection fraction, who reports for a medication management clinic. He has queries about his lab notification letter, which indicates a slightly elevated BNP. My question to you is, which of the educational points below would be correct with regard to this report? Is it BNP shouldn't be used to assist with the diagnosis of exclusion of heart failure as a cause of symptoms such as dyspnea and weight gain? Or is it true that patients who are on sacubitril co-formulated with valsartan therapy have elevated BNP levels? Or is it true that elevated BNP is only due to cardiac causes? Or is it true that BNP and N-terminal pro-hormone BNP, which is abbreviated as NT-proBNP, are exactly the same and can be used interchangeably? I'll give you 10 seconds to choose the correct answer. Opinion B is the correct answer. BNP and not NT-proBNP is a substrate of neprilysin. Therefore, an angiotensin receptor co-formulated with a neprilysin inhibitor, which is abbreviated as an ARNI, such as the product valsartan co-formulated with sacubitril, increases BNP levels. Therefore, NT-proBNP will not change. Now, BNP can be used to assist with the diagnosis or exclusion of heart failure as a cause of symptoms such as dyspnea and weight gain. In the emergency setting, BNP levels are usually have a higher sensitivity than specificity, and may be more useful for ruling out than ruling in heart failure. I'd like to emphasize that elevated BNP levels are associated with a variety of cardiac and non-cardiac causes. Examples of the cardiac causes include heart failure, acute coronary syndrome, valvular heart disease, atrial fibrillation, cardiac surgery, and even cardioversion. And among the non-cardiac causes, we may have advanced age, anemia, renal failure, critical illness, obstructed sleep apnea, even some cases of pneumonia, and even pulmonary hypertension can lead to it. Now, BNP and NT-proBNP are both natriuretic peptide biomarkers. Their absolute values and cutoff points can't be used interchangeably. Now, as per the AHA stroke ACC stroke H Heart Failure Society of America Heart Failure Guidelines, for patients at a risk of developing heart failure, natriuretic peptide biomarker-based screening followed by a team-based care, including cardiovascular specialists optimizing the guideline-directed medication therapy, can be useful to prevent developing left ventricular dysfunction. Now, B.N.P and NT-proBNP are measured as simple blood tests. They do not require fasting or prior preparation before the tests, unlike lipids and those sugars, for example. Just as a by the way, let's move to the next question. JBO is diagnosed with vasospastic or principal angina with normal coronary arteries, according to the cardiac catheterization report from your hospital. Which of the pharmacologic options listed below would be the most appropriate to reduce angina-related episodes in the case of JBO? Would it be Metoprolol, Fosinopril, Verapamil, or spironolactone? I'll give you 10 seconds to choose the correct answer. I would settle for Verapamil. Now, calcium channel blockers and nitrate therapy effectively dilate epicardial coronary arteries, which is beneficial to minimizing or in some cases eliminating vasospastic angina symptoms. Now, unlike typical angina associated with coronary artery obstruction, beta blockers are ineffective in vasospastic angina and may actually worsen coronary vasospasm via an opposed alpha-1 receptor activity. So you have to be very careful when choosing the mode of therapy. Lisinopril alternative B and spironolactone alternative D both can provide blood pressure lowering effects that are useful in typical angina patients, that is by reducing myocardial oxygen demand. But for control of coronary spasm, in my opinion, they are not appropriate at all. So that just explains in many words why Verapamil would be the drug of choice. Let's move to the next slide, please. The question reads, KLP, a 50-year-old Hispanic man who is newly diagnosed with hypertension, reports to the clinic for the initiation of pharmacologic treatment. He has a past medical history of type 2 diabetes mellitus and he is obese. Currently, he takes 500 milligrams of metformin after breakfast and dinner, and additionally he takes 5 milligrams of glimepiride twice daily. So my question to you is, which statement below is appropriate concerning KLP? Would you set a BP goal below 120/85 and initiate Fosinopril? Or would you set a goal of below 140/90 and start nifedipine? Or would you set a goal of below 140/90 and initiate ramipril? Or would you set a goal of below 150/90 and initiate amlodipine? I'll give you 10 seconds to choose the correct mode of action, or mode of intervention rather. So personally, I would set a goal of be less than 140/90 and initiate ramipril. Remember, KLP has a diagnosis of type 2 diabetes mellitus and is in need of antihypertensive therapy. Now his goal, BP, in my opinion, is below 130/80. Now, the guidelines also recommend the use of an S inhibitor or an ARB if the S inhibitor can't be tolerated, as the preferred initial choice in patients with diabetes mellitus. Now, this makes answer C the best option of all the rest. Remember, the goal in A is too low, and the drug choice in B is wrong. The drug choice in D is wrong, and though the 140 is above our goal slightly, option B would offer us the best way out in this particular patient's case. Let's move to the next slide, please. A.M.D, a 69-year-old white female, presents to the clinic for dyslipidemia management with a past medical history of coronary artery disease, status post-coronary stent. She also suffers from type 2 diabetes mellitus. She is hypertensive and obese. She currently takes 81 milligrams of aspirin once daily, 16 milligrams of candesartan and ARB once a day, 1,000 milligrams of metformin after breakfast and dinner, and supplements with multivitamins. She smokes 1 packet per day but doesn't drink alcohol, and she doesn't take illicit drugs. Her most recent fasting lipid panel report was as follows. Total cholesterol was 243, HDL 56, LDL 139, TG 240, and the glucose was 115, and her 10-year cardiovascular risk is estimated at 11%. So my question to you is, which of the statements below is the most correct regarding A.M.D's case? Is it true that she needs LDL reduction of at least 30% with the initiation of fenofibrate? Or is it true that she needs LDL reduction of over 50% and we should initiate rosuvastatin? Or is it true that her LDL goal should be below 130 and we should initiate ezetimibe? Or is it true that her goal is below 130 and we should initiate pravastatin? I'll give you 10 seconds to choose the correct answer. I would settle for B. I would seek to reduce the LDL by over 50% and initiate rosuvastatin. Now, this patient has a history of type 2 diabetes mellitus. She has a known coronary artery disease. She already has a coronary stent in place, and her 10-year risk is above 7.5%, which makes her a candidate for high intensity statin therapy, meaning she should have a reduction in her LDL cholesterol by at least 50%. Now, only atorvastatin and rosuvastatin will provide adequate lowering of LDL cholesterol by over 50% from the baseline value. The other statins are mild. Now, from the options above, rosuvastatin would be the most appropriate choice, given that it targets the low density lipid, the LDL cholesterol, to be specific. Now, in my opinion, fenofibrate has a small LDL reduction component. I would not be biased towards it. It's usually prescribed mainly for TG lowering and is not appropriate for initial therapy, especially given the strength of data supporting statin use in secondary coronary artery disease prevention. Ezetimibe in alternative C usually only causes a reduction in LDL cholesterol by 20 to 30% and would be insufficient alone, but it can be an add-on to a potent statin. Patients at a high risk for future ASCVD events include patients over the age of 65, those who are in the category of heterozygous familial hypercholesterolemia, or those with a history of cabbage or PCI who have established coronary artery disease, those with diabetes mellitus, those who are hypertensive, those with CKD with an eGFR of between 15 and 59, or those who are currently smoking, or those with LDL cholesterol above 100, or those with a history of heart failure. Yeah, I would consider those ones as high-risk patients. And just like to add that statins and ezetimibe both lead to upregulation of LDL receptors at the liver level, and that can extract LDL cholesterol out of circulation. That makes them useful in the lowering of LDL cholesterol, just for your information. Let's move to the next slide. JJJ, a 34-year-old male patient suffering from pulmonary hypertension, presents to the clinic. He belongs to the WHO functional classification 2. He has been taking iloprost for half a year without achieving the desired clinical outcome. So my question to you is, which of the recommended changes listed below would you make to JJJ's regimen? Would you add IV epoprostenol, or would you change his regimen to ambrisentan and add tadalafil to it, or would you add high-dose furosemide to his regimen, or D, would you add nifedipine to his regimen? I'll give you 10 seconds to choose the correct answer. So I would change to ambrisentan and add tadalafil to this patient's regimen. Now, combination therapies are indicated for certain patients with pulmonary hypertension in order to optimize therapeutic or clinical outcomes. Now, in the case of our patient JJJ, who belongs to the WHO functional class 2, the combination of choice will be ambrisentan and tadalafil, which happens to be I think a 1B recommendation according to literature, combining two prostacyclin analogs, that is alternative A, which recommends addition of epoprostenol to iloprost, wouldn't be beneficial. Remember, JJJ has a negative vasodilator test, if I remember well, and wouldn't benefit from nifedipine either. So D would also be wrong. High dose furosemide, in my opinion, would be the best choice for him, but I'll underline the word but, may be considered if there is edema not resolved by other drug therapy modifications. I would not rush to nifedipine. Now, agents such as epoprostenol that must be continuously administered via IV pump carry a risk of catheter-related infections. That's why I would not favor it so much. And I would just like to remind you that acute decompensation of PAH and hypertensive episodes may occur if the rapid-acting prostacyclin analogs are abruptly discontinued, or if their infusion reservoirs are emptied. So you have to be very careful when administering epoprostenol or an agent like iloprost. You have to be very cautious when using them. Just also like to add that bosentan, which falls in the same class like ambrisentan, carries a black box warning for hepatotoxicity and requires baseline and monthly liver function testing, just in case you opt to use it. That's just a by the way for your information. Let's move to the next slide, please. P.M.B, a 47-year-old male patient, presented to the cardiac clinic with a past medical history of type 2 diabetes mellitus, with a history of hypertension. The BP then was 149/97, and Lisinopril 20 milligrams once daily was initiated. 90 days later, his home BP still reads 146/79, and the same is confirmed at the clinic. So my question to you is, which of the interventions listed below would be the next best or most reasonable intervention in the case of P.M.B, whose blood pressure doesn't seem to be well controlled? Would you opt to leave status quo, or would you increase the lisinopril dose to 40 milligrams once daily, or would you consider adding hydrochlorothiazide at a dose of 25 milligrams after breakfast, or would you change his lisinopril to hydrochlorothiazide at a dose of 50 milligrams once daily after breakfast? I'll give you 10 seconds to choose the correct answer. Settle for answer B and increase the lisinopril dose. Remember, it's not yet a target. Now, P.M.B isn't yet at his blood pressure goal of less than 130/80. He has a compelling indication, which is the presence of type 2 diabetes mellitus, for an ACE inhibitor over the other classes of antihypertensive drugs. Now, monotherapy is generally preferred when sufficiently working to improve adherence. Remember, his BP is coming down. Before we add a second agent, we can choose to stick to monotherapy and tweak the dose a little bit. Now, P.M.B hasn't had his lisinopril dose optimized. Therefore, increasing the dose before adding another drug of a different class would appear reasonable to me. I would do that. If, however, his blood pressure remains or still doesn't reach goal, then there might be need to add additional antihypertensive therapy. And a thiazide diuretic such as chlorthalidone, hydrochlorothiazide, indapamide, or even metalazone, in my opinion, would be appropriate additions to his therapy. Now, patient factors that may contribute to avoiding the use of thiazide diuretics may include creatinine clearances below 30/40, the presence of gout, for example, or hyperuricemia, and or uncontrolled serum glucose levels, or even diabetes mellitus itself, because we know that thiazides have a tendency to increase serum glucose levels. That's just a by the way. Let's move to the next slide, please. SMM, a 44-year-old female patient, presents to the clinic with a past medical history of periodically treated hypertension and an uncontrolled atrial fibrillation. Today, the vitals include a systolic blood pressure of 156, diastolic 92, the heart rate of 106, pretty high. So my question to you is, which of the interventions listed below would you consider most appropriate for SMM's hypertension and atrial fibrillation today during this clinic visit? Would you consider metoprolol tartrate at a dose of 200 milligrams twice daily orally, or would you consider verapamil SR at a dose of 120 milligrams once daily orally, or would you consider 5 milligrams of amlodipine once a day orally, Or would you administer 0.125 milligrams of digoxin once daily? I'll give you 10 seconds to choose the correct answer. Opinion B, it is. I would consider introducing verapamil SR at a dose of 120 milligrams once daily. Now, amlodipine is a dihydropyridine calcium channel blocker which doesn't reduce AV nodal conductance, unlike the non-dihydropyridine calcium channel blockers like diltiazem and verapamil. Digoxin, on the other hand, is a cardiac glycoside which suppresses AV nodal activity through an increase in parasympathetic tone. Now, this may slow the heart rate, but it doesn't lower blood pressure. Metoprolol tartrate, on the other hand, might be an appropriate agent, but the dose of 200 PD is incorrect. The tartrate form has a shorter half-life and should be administered in divided doses twice daily. Now, 200, in my opinion, is a very high starting dose. Now, the succinate form of metoprolol can be administered once daily due to its release characteristics compared with the tartrate. Verapamil, in my opinion, is a non-dihydropyridine calcium channel antihypertensive that causes both smooth muscle dilatation in blood vessels, and it also slows automaticity and conduction in the AV node, and would therefore be an appropriate choice. So that makes B the correct answer. Let's move to the next slide, please. E.A.N, a 59-year-old Caucasian male, presents to the cardiac clinic with a past medical history of type 2 diabetes mellitus and hypertension. Today, his A1C reads 6.9%, and his average blood pressure is 139 systolic, 90 diastolic. Other lab results are within normal limits. So, in your opinion, what would be E.A.N's blood pressure goal according to the ADA guidelines and according to the ACC/AHA 2017 guidelines? Would it be the ADA guidelines recommend a BP goal of 150/90 and the ACC/AHA guidelines recommend a goal of 130/90? Or is it B, the ADA guidelines recommend a goal of 140/90 and the ACC/AHA recommend a goal of 130/80? Or is it C, the ACC/AHA BP goal of 130/80? Or is it a goal of 140/90? I'll give you 10 seconds to choose the correct answer. Settle for B. Now, the ADA guidelines recommend a goal of 140/90 for most patients. The ACC/AHA guidelines recommend the goal of 130/80 for the general population and for those with type 2 diabetes mellitus. The JNC8 recommends a goal of 150/90 for the general population over 60 years of age without chronic kidney disease or diabetes mellitus. The ADA guidelines recommend a goal of 130/80 for patients with a high cardiovascular risk who are able to reach the stricter goal with no adverse effects. Now, this patient E.A.N isn't considered to have high cardiovascular risk. He doesn't smoke, he doesn't have a coronary artery disease, neither has he been stented before. Now, the ACC/AHA 2017 hypertension guidelines based their recommendations on the results of recent trials and meta-analysis, most notably the SPRINT trial, SPRINT trial, which formed the basis of the low blood pressure goals in the new guidelines. I would recommend you read about the SPRINT trial in your own time, just to understand where I'm coming from. Let's move to the next slide. ZAJ, a 26-year-old pregnant patient in the second trimester of pregnancy, to be specific, is diagnosed with a PE. Currently, she administered enoxaparin at a dose of 1 mg per kilo sub-Q twice daily. So my question to you is, which of the therapeutic strategies below would be suitable would be a suitable long-term therapeutic option for Lady ZAJ? Would you consider administering warfarin at a dose of 5 mg once daily and keep the INR within the range of 2 to 3? Or would you administer enoxaparin at a dose of 1.5 mg per kilo sub-Q once daily? Or would you administer enoxaparin at a dose of 1 mg per kilo sub-Q once daily? Or would you consider administering warfarin 5 mg once daily and keep the INR within the range of 1.5 to 2? I'll give you 10 seconds to choose the correct answer. So the correct answer is B, in my opinion. Enoxaparin 1.5 mg per kilo sub-Q once daily is the most appropriate choice for pregnant patients. Now, enoxaparin 1 mg per kilo sub-Q twice daily is also appropriate. However, using the OD or once daily dosing of 1 mg per kilo must be used. Now, warfarin is contraindicated in pregnancy and shouldn't be used, except, and there's one exception, in patients with mechanical heart valves. In all other situations, please avoid it. While oral anti-10A inhibitors and oral direct thrombin inhibitors have demonstrated adverse events and effects in animal models, there is insufficient evidence to recommend therapeutic use in pregnancy for VTE treatment. So I would not gamble and try to use them in a patient like this one in pregnancy. Now, low molecular weight heparin is the preferred anticoagulant therapy in pregnant patients with acute VTE. Now, fibrinolysis carries a risk of hemorrhagic complications in pregnancy and hasn't been appropriately evaluated in human studies. However, in life-threatening PE and considering the risks versus the benefits, fibrinolysis may be considered in PE in pregnant ladies. Now, warfarin may be used in breastfeeding women who are postpartum because it doesn't appear to pass into breast milk. But avoid it during pregnancy. You can use it exceptionally during breastfeeding where there's an indication. Just as a by the way, let's move to the next slide, please. A 46-year-old patient is being evaluated for drug-induced pulmonary arterial hypertension due to long-term cocaine abuse or addiction. The cardiologist in your clinic consults the pharmacy department for drug therapy guidance after this patient's positive vasodilatory test. So my question to you is, which of the drugs listed below would be the most appropriate to initiate at this time? Would you opt to initiate epoprostenol, ambrisentan, riociguat, or nifedipine? I'll give you 10 seconds to choose the correct answer. So I would settle for nifedipine. Now, due to the positive test, calcium channel blockers are the drugs of choice for initial management of patients such as this one. All the other agents would only be considered once the calcium channel fails or the patient is no longer vasoreactive or vasoresponsive. High-dose calcium channel blockers are often used in PAH. For example, amlodipine at doses of 20 to 30 milligrams daily, or nifedipine at a dose of 120 to 240 milligrams daily. They may appear abnormally high. In hypertension, you would not do that, but in the case of PAH, such high doses can be used. Now, as the PAH progresses, patients who once had positive acute vasodilatory tests may become unresponsive. At this time, therapy should be re-evaluated. I would like to add that dihydropyridine calcium channel blockers are the preferred choice, since the non-dihydropyridines like verapamil have excessive negative inotropic effects and would therefore complicate the patient's treatment with unbearable side effects. Just as a by the way, let's move to the next slide, please. JIK, a 68-year-old Caucasian male, presents with a coronary artery disease status post stent placement 72 months ago, 3 years ago, and a history of type 2 diabetes mellitus during a visit at the Cardiology clinic. He currently takes 40 milligrams of rosuvastatin at bedtime, and he tells you he follows a healthy lifestyle. Some of the fasting lab results include a TC of 171, a TG of 99, an LDL cholesterol of 114, an HDL of 37. So my question to you is, how would you best address JIK's elevated LDL cholesterol levels? Would you do so by changing rosuvastatin to atorvastatin 20 milligrams at bedtime? Or would you add 10 milligrams of ezetimibe once daily to his current regimen? Or would you leave status quo? Or would you add fenofibrate 145 milligrams once daily to the current regimen? I'll give you 10 seconds to choose the correct answer. Personally, I would add ezetimibe at a dose of 10 milligrams once daily to the current therapy. The lipid guidelines recommend high intensity statin or maximally tolerated statin therapy for patients with a diagnosis of clinical atherosclerotic cardiovascular disease such as this one. The guidelines also state that we should consider adding ezetimibe if on maximal statin intensity and the LDL still remains above 70. Now, in my opinion, atorvastatin 20 milligrams is a moderate intensity statin therapy and would therefore be unsuitable. That makes answer A wrong. Fenofibrate, on the other hand, is primarily used for triglyceride lowering, and it can increase LDL cholesterol values, and that makes answer D wrong as well. And because the lipids are not controlled, I would not leave status quo. That makes answer C wrong as well. Now, coronary artery disease with stent placement with multiple risks factors such as diabetes mellitus, an age of above 65, makes a patient classified as very high risk clinical ASCVD, and the target LDL should be below 70. Now the Improve It trial, IMPROVE-IT trial, showed long-term cardiovascular benefits when adding ezetimibe 10 milligrams to simvastatin 40 milligrams in high-risk post-acute coronary syndrome patients, and that is the basis on which I would comfortably add ezetimibe to rosuvastatin in the management or in the lowering of LDL cholesterol in this patient's case. Just as a by the way, let's move to the next slide, please. STA, 78-year-old male patient who weighs 78 kilos is admitted to your hospital for the management of his left leg cellulitis. He has a past medical history of type 2 diabetes mellitus, hypertension, and chronic kidney disease. Some of his pertinent labs include, on day 3 of hospitalization, include a serum creatinine of 2.6, glucose of 195, HB of 113.2. His platelets are 223,000. The chest CT shows a pulmonary embolism, and he will require anticoagulation. So my question to you is, which of the options listed below would be the most appropriate for Mr. STA now? Would you opt for apixaban 5 milligrams twice daily for 3 weeks? Would you administer heparin at a dose of 60 units per kilo IV bolus followed by 12 units per kilo IV continuous infusion every hour? Or would you administer enoxaparin at a dose of 1 milligram per kilo sub-Q once daily? Or would you settle for fondaparinux at a dose of 2.5 milligrams sub-Q once daily? I'll give you 10 seconds to choose the correct answer. Comfortable with administering enoxaparin at a dose of 1 milligram per kilo sub-Q once daily. Now this patient's estimated GFR is approximately 25.4, and the most appropriate choice would be enoxaparin 1 milligram per kilo sub-Q once daily, which is the correct renally adjusted medication considering the given options above. The dose of heparin listed in alternative B is the correct dosing for NSTEMI or STEMI, and it's not appropriate for PE at all. So that makes alternative B wrong. Fondaparinux, I'll have big question marks here. It shouldn't be used in patients with a GFR less than 30 according to the literature insert. That makes alternative D wrong. And apixaban hasn't been adequately studied in patients with a serum creatinine greater than 2.5. Remember, our patient's value is at 2.6, so that would also make alternative A wrong. Now, while oral anti-10A inhibitors have dosing recommendations for patients with renal impairment, caution must be taken since their doses are generally based on extrapolated and simulated data rather than prospective human research. Just for your information. Let's move to the next slide, please. A 72-year-old white man is classified stage B heart failure. He has a left ventricular ejection fraction of 35%. Some of his vitals include a systolic blood pressure of 153, diastolic 95, with a heart rate of 82, a bit high. Some of the pertinent labs include a serum creatinine of 1.1 with potassium levels of 4.2. My question to you is, Which of the regimens listed below would suit this patient the most? Would it be Fosinopril plus Metoprolol, succinate and Furosemide, or would it be Lisinopril plus carvedilol, or would it be isosorbide dinitrate, hydralazine and bisoprolol? Mark his race. Or would it be enalapril and atenolol? I'll give you 10 seconds to choose the correct answer. Would settle for lisinopril co-administered with carvedilol. According to the ACC/HA guidelines, the use of a beta blocker with heart failure data such as carvedilol, metoprolol, succinate and bisoprolol, and an ACE inhibitor would be the most appropriate and preferred option in this patient's case. Now, the addition of furosemide, which is in alternative A, would be necessary in stage C patients once the heart failure symptoms manifest, not at this stage. So I would consider answer A wrong. Isosorbide dinitrate and hydralazine combination has mortality data in heart failure patients, especially in the black race. It isn't preferred over the ACE inhibitors given the results of head-to-head trials showing greater benefit in ACE inhibitor treated patients. Positive data for use of isosorbide dinitrate and hydralazine is in the African American population, and we are told this patient is a white man, so it wouldn't be a favorite choice. Just as a by the way, let's move to the next slide. A 69-year-old Kenyan man presents to the cardiac clinic at the E.A.N. University Hospital, Nairobi, with a past medical history of hypertension, type 2 diabetes mellitus, gout and allergic rhinitis. He denies any complaints and confirms his compliance with the current regimen. He currently takes 300 milligrams of allopurinol once daily orally, 25 milligrams of atenolol orally once a day, 5 milligrams of glipizide twice daily, and loratadine 10 milligrams once a day for his allergic rhinitis. Some of his pertinent lab results include an A1C of 7.2%. The other labs are within normal limits. He has a systolic blood pressure of 134, diastolic 74, with a heart rate of 48 on the lower side. The atenolol could be causing havoc. So he has taken charge of his treatment and he has been monitoring his BPs while at home, and he has kept a log, and the average diastolic happens to be 138, the maximum of 146, minimum of 132. The average systolic is 72 with a maximum of 74 and the minimum of 70. And the pulse, the average is 49 with a maximum of 52 and minimum of 45. So based on the information tabulated above, what is the patient's goal blood pressure, and what would be the most appropriate therapeutic recommendation for this patient now? Would it be a goal of below 140 systolic, 95 diastolic, and would you choose to discontinue atenolol and initiate Fosinopril at a dose of 10 milligrams once daily? Or would you set the goal at below 130/80 and discontinue atenolol and initiate Fosinopril 10 milligrams once daily? Or would you set the goal at below 130/80 and increase the atenolol dose by doubling it? Or Would you set the goal at less than 150/90 and continue the current therapy? I'll give you 10 seconds to choose the correct answer. Settle for alternative B. This patient's ideal goal is 130/80. Now, according to these results, he is bradycardic as per the home BP log and the clinical vitals, presumably due to the atenolol therapy, the beta blocker. Now, due to the compelling indications, type 2 diabetes mellitus to be precise, an S inhibitor would be the preferred treatment for hypertension in this patient's case. Now, the most appropriate option would be to stop atenolol and start an S inhibitor, which in our case is Fosinopril. So that makes B the correct answer. Let's move to the next question. This PLK, 70-year-old male, presented to the A&D with supraventricular tachycardia and underwent direct current cardioversion, which temporarily resolved the arrhythmia. Now, according to the EKG, he is back into supraventricular tachycardia. He is hemodynamically stable but complains of muscle soreness from the cardioversion, most probably. He has a past medical history of heart failure, poorly controlled asthma, stroke COPD. He has an overlap of both. He doesn't recall the medicine he's supposed to take. So my question to you is, which of the options listed below would be the most appropriate treatment for his supraventricular tachycardia? Would it be IV propranolol at a dose of 2 milligrams? Would you choose to administer 400 milligrams of dronedarone at a dose of 400 milligrams once daily? Would you choose to administer 0.5 milligrams of digoxin IV, or would you administer 6 milligrams of adenosine IV? I'll give you 10 seconds to choose the correct answer. So I would settle for digoxin 0.5 milligrams IV. Now, reactive airway disease, that is asthma, COPD, is a relative contraindication to adenosine and propranolol therapy for SVT. That excludes alternatives A and D. Now, pre-existing heart failure is a concern in the evaluation of dronedarone therapy. Now, given the history of poorly controlled asthma, stroke COPD, and heart failure, the most reasonable choice for PLK is digoxin, which can induce rate control due to its increased parasympathetic activity on the AV node. Appropriate alternatives would include amiodarone, sotalol, and dofetilide. Now, digoxin load is typically 0.25 to 0.5 milligrams via IV bolus, which is then followed by 0.25 milligram boluses at every 6 to 8 hour intervals. Now, be very careful because it can be toxic. Up to a maximum dose of 1 milligram over a 24-hour period. Do not exceed that, for God's sake. Now, while hyperkalemia is a marker of digoxin toxicity when initiating digoxin, hypokalemia predisposes the patient to digoxin adverse events. So those are things you need to look out for. And I would just like to add that digoxin is a sodium potassium ATPase channel antagonist, and it ultimately allows for sodium calcium exchange, leading to intracellular calcium dependent calcium release, and numerous secondary effects which include increased inotropy and enhanced diastole. So watch out for side effects that could be linked to those. Let's move to the next question, please. It reads, which of the beta blockers listed below reduces mortality in heart failure and is also FDA approved for heart failure treatment? Is it bisoprolol, carvedilol, atenolol, or propranolol? I'll give you 10 seconds to choose the correct answer. Carvedilol it is. Now, beta blockers have differences in their PK and PD profiles. They also differ in the evidence supporting their use and approved indications for specific conditions. Those that are known to reduce mortality in the treatment of heart failure are mainly those with left ventricular dysfunction, may include drugs such as bisoprolol, metoprolol succinate, or carvedilol, according to literature. However, metoprolol succinate and carvedilol are the only ones with FDA approval for indications in heart failure, whereas bisoprolol does not have FDA approval for the same. I would just like to add that atenolol is a water-soluble or a hydrophilic beta-1 selective beta blocker that is FDA approved for use in acute MI, angina pectoris, due to coronary artery disease and hypertension as an adjunct. It is not approved for use in heart failure. That makes answer C incorrect. Our propranolol, which is answer D, is a hydrophobic or lipophilic non-selective beta blocker that is FDA approved for cardiac arrhythmias, essential tremor, hypertension, migraine prophylaxis, HOCM, pheochromocytoma. It can be used post-MI, and it can also be used in stable angina, but it is not used in heart failure. That makes answer D wrong. And I would just like to emphasize that one of the benefits of beta blockers in the treatment of heart failure is the ability to inhibit remodeling. That is proven in metoprolol succinate, in bisoprolol, and in carvedilol. So they prevent remodeling of the heart that leads to an increased risk in cardiac death, sudden cardiac death to be specific. Metoprolol succinate, I would just like to remind you, is a scored tablet that can be split into two while retaining its extended release properties, but we discourage chewing and crushing because that affects the release of the active ingredient. It ceases to be extended release when you crush it or when you chew it. Now, metoprolol tartrate, not succinate, is dosed twice daily and does not have FDA approval for use in heart failure. Those are just by the ways. Let's move to the next question, which reads, which of the diuretics listed below confers benefit by reducing mortality among patients with New York Heart Association classes 3 and 4 heart failure? Is it furosemide, clothalidone, spironolactone, or hydrochlorothiazide? I'll give you 10 seconds to choose the correct answer. In my opinion, spironolactone it is. Of the listed diuretics, only aldosterone antagonists are known to reduce mortality in heart failure patients. This is specifically true for patients in classes 3 and 4 heart failure. Now, the so-called RALES trial, R-A-L-E-S trial, was stopped early due to significant reduction in mortality with the use of spironolactone in patients mainly in class 3 heart failure. I would also like to add that the Ephesus trial, EPHESUS trial, was done with eplerenone and also showed benefit in the heart failure population. The other diuretics, that is chlorothalidone and hydrochlorothiazide and furosemide, don't reduce mortality specifically in this scenario and are used more for controlling hypertension or symptoms of heart failure. Ladies and gentlemen, that brings us to the end of part 33 of our pharmacotherapy MCQ series. If this video helped you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your friends. I appreciate the fact that you made time to listen to me and to watch this video. I would like to promise you that the best is yet to come, and I would like to remind you that I hope to interact with you in part 34 of our series. Thank you for always being there for me.